It is with the utmost enthusiasm that I introduce our opening plenary speaker, Dr. Josh Jordan, a visionary psychiatrist, an outstanding neuroscientist in his own right, who was appointed as the director of the National Institute of Mental Health in 2016. He has been an extraordinary advocate for expanding research efforts related to mental health, and in particular to mental health disparities. He has championed the United States investment in mental health research that translates basic science insights into transformative treatments and uses precision medicine approaches to revolutionize clinical care for patients with mental health illnesses. Dr. Gordon came to the role of the NIMH director at a time when we were already recognizing the extreme limitation of our self-report models of mental health, and that there was an increased recognition that we needed to understand the fundamental biological mechanisms subserving these disorders. But he more than took on the mantle of his predecessors. Dr. Gordon's leadership has moved the field even further forward to what I believe is one of the most comprehensive integrated visions for mental health our field has experienced to date. Rather than pitting false dichotomies between biology and behavior, he has led the field to embrace and integrate the full spectrum of factors that influence the brain, from the social determinants of mental health to consideration of our individual genetics, brain circuitry, cognitive information processing systems, physiological systems, and also to make sure we're utilizing the best models and tools from optogenetics to induce pluripotent stem cell models of mental health, and bringing these together in a systematic manner driven by empirically based data science and efforts that can only help to accelerate the development of our understanding of our personalized interventions, fulfilling the dream of precision mental health. Over the years, his work has been recognized across multiple domains. His leadership has been recognized by many, many prestigious awards, from the A.E. Bennett Research Award from the Society of Biological Psychiatry and the Daniel Efron Research Award from the American College of Neuropsychopharmacology. We are simply thrilled that he can join us virtually and lead us off today. Please join me in welcoming Dr. Josh Jordan.
Thank you really very much for that overly kind introduction. And listening to it, I was wondering who you might be speaking about, but I do appreciate the look at what we've been trying to do at NIMH since 2016. And hopefully I'll give you a little bit of a flavor of that integration in the talk that I'm going to be providing today. Just making sure that you all can hear me. It's lonely here out in Bethesda, Maryland. But I assume since no one's shouting at me on the chat that you can. Let's go over what I hope to convey to you in this time I have to spend with you. And let me first say I apologize that I can't be there in person today. The travel arrangements would have been too challenging with some obligations that I had yesterday and indeed tomorrow. The agenda for today is really to examine the frameworks that we have currently for precision psychiatry, to look at opportunities to re-examine some of those frameworks, and as presaged by the introduction, really talk about trying to figure out how we might foster integrated large-scale approaches to furthering precision psychiatry. And then, as was mentioned, one of the things that we care a lot about as we move towards precision psychiatry is including a diversity of perspectives. And a lot of that means we need to focus on the workforce. And so I want to talk to you about some workforce diversity initiatives that will impact how we move forward into this brave new world. Let me apologize in advance. If I exclude in this talk the wonderful work that some of you and some around the globe are doing in other aspects of precision psychiatry that I don't cover, for example, the wonderful work being done from a physiological perspective to examine individual patients and design treatments that are targeted at their individual physiologies. I'm not going to have time to cover that today, but that is an important aspect of precision psychiatry that will play a little bit into the integrated approaches, but is really something we're ready to move forward on now, and many of you here are doing it. So I'm going to focus on some other aspects instead for the bulk of this talk. So let's talk about frameworks for precision psychiatry. At the National Institute of Mental Health, we think about frameworks a lot. We think about frameworks across our entire strategic plan, which, as hinted at again in the introduction, includes work done to define the brain mechanisms underlying behavior, to examine mental illnesses across the lifespan, to develop new preventative and curative therapies, and to ensure through services and implementation research that all the research that goes on in the other three goals has actual public health impact. The precision medicine initiatives that NIMH supports really cover all four of those aspects of our strategic plan, although, as noted here in the paragraph on the right, which I won't read, but you can if you like, is highly specialized, particularly in the efforts to improve our ability to prevent, treat, and cure mental illnesses. We really strive in that goal in particular to develop approaches that will help us utilize existing treatments better, as well as, although I won't talk about it so much, to develop truly novel therapies that are precisely targeted at individuals. The efforts to use our existing treatments better are, I think, well illustrated by research that's being conducted in what is one of the most pressing issues of the day, suicide prevention research. You all know that for the last 2 decades, suicide deaths in the United States and suicide death rates in the United States have been mostly inexorably rising. We had a break for a couple of years, but the latest data from the CDC suggested that, again, in 2021, suicide deaths did rise at least year over year, re-reaching the level they were at in 2019. And some time ago, individuals from NIMH, as well as experts in suicide prevention research and advocacy groups and other federal agencies, set out a prioritized research agenda for suicide prevention that had as its ultimate goal reducing the death rate by suicides by a quarter. And that led us to think, well, quantitatively, how can we do this? How can we recognize individuals and precisely deliver the kind of care that they need, individuals who are at risk for suicide? And one of the ways that we can do this, it's certainly not the only way, was obvious, again, looking at the numbers, and that suicide decedents, people who die by suicide, are accessing healthcare with regularity prior to their death, and up to 50% within the 30 days prior to deaths by suicide, and over 90% within the previous year. So if we had ways during healthcare visits of identifying individuals at risk, we could target interventions to those most at risk. That recognition, that realization led to a number of different efforts within the context of healthcare to identify tranches of individuals who belong to high-risk groups. The first of these, I'm showing these results on this slide, was done in the context of the VA system, looking at veterans coming in for all kinds of care, including primary health care. And you can see that using an algorithm that combined answers to clinical surveys as well as demographic information and information about, in this case, those veterans' service records, they could identify the tranches of individuals who are on the left-hand graph, who were 140 times more likely to die by suicide in the month after an initial encounter. And then larger groups of individuals who were 60, 40, and even 20 times more likely to die by suicide. And importantly, these suicide rates for those individuals in these tranches were quite high as 6,000 individuals per 100,000. With this kind of data in hand, it allowed the VA and now other healthcare systems to dedicate resources to individuals belonging to these groups, such as referral to psychiatric care, referral to further evaluation, and inclusion in resource-intensive programs that we know can reduce suicidality, such as dialectical behavioral therapy. This risk identification has spread from the VA to a number of different settings, including health management organizations in the public and the private sphere. And in fact, these algorithms combined with at point of care assessments can reliably recognize individuals who are at high risk. One example of this is work from the ED STARS study, which is an emergency room-based study that uses a computerized adaptive screen in all children showing presenting to the emergency rooms in the study for any reason. And the computerized adaptive screen is successfully able to identify over 80% of youth who would go on to attempt suicide in the next 3 months, as well as correctly identify with specificity about 72.5% of people who did not attempt suicide. So these are very good numbers when you think about trying to take at-risk populations and get them the care that they need. We can do better, though. And so NIMH research is providing additional clues as to how we might identify risk with even finer timeframes than, let's say, the ensuing 3 months. Shown on the left is the results of inpatient individuals wearing a wristband that monitors their activity and that can reliably detect, at least for a subset of adolescents in inpatient care, periods of time when they are experiencing high levels of suicidality. And on the right, an ecological momentary assessment tool that sends out queries to adolescents after inpatient discharge that can track their suicidality over time and hopefully indicate periods of elevated risk where clinical intervention can reduce that risk. So we can imagine through a combination of these algorithms and technological solutions, refining our resource allocation to those highest at risk and developing these new tools to be able to monitor that risk over time so that we can reduce suicide death rates really across the United States. Now, we don't want to just do this for suicide. We want to do this across the spectrum of mental illness and indeed across the spectrum of illness. And many of you are familiar with the NIH All of Us research program, which is really a historic effort to advance precision medicine by collecting and studying data from 1 million individuals living in the United States, fully representative of the population of the United States, combining ongoing assessments of health and other issues, including social determinants of health, with electronic health records and genomics to allow us to probe the determinants of health in these individuals, which are again representative of all populations in the US, and develop new approaches to delivering precision health. We'd like to take advantage of this resource at NIH, and I encourage those of you who who are interested to take a look at the data that's available. Already, they have released a number of different data sets that include physical measurements, electronic health records, Fitbit records, and survey responses. And although, as was discussed earlier, self-report isn't necessarily the best way to move forward with precision mental health, the self-report data from the All of Us research program does indicate that within the first 200,000 or so individuals for which data is available now, there are substantial numbers of individuals with psychiatric diagnoses, including major depressive disorder, bipolar disorder, and even schizophrenia, at rates that match or sometimes exceed the base expected prevalence of these illnesses in the general population in the United States. So the All of Us program is, and you'll hear more about it in a moment, what we hope will be a true resource to enhance precision psychiatry for all of Americans. So those are it gives you some idea of the frameworks that we have right now within precision psychiatry. We have algorithmic and technological approaches to identify individuals who belong to high-risk categories. I mentioned, of course, but didn't show the work that we're doing to try to design precision therapies for individuals. But I think we need to re-examine our frameworks if we want to truly transform the psychiatric approach to precision therapies and precision prevention measures. And the first place that I want to start with this re-examination is to think about what we even mean when we talk about using data approaches and theoretical approaches to discovering new precision efforts. And then I want to talk about what we mean when we talk about a diagnosis and how the current use in the vernacular of the word diagnosis actually impedes our ability to make progress in this area, and how we might think about reframing our approach, our thinking around diagnoses in order to advance precision psychiatry. So let's talk about data-driven versus theory-driven approaches. And I thought I'd give you an illustration of what we're currently supporting in the area of data-driven and theory-driven approach to precision psychiatry before I talk to you about what we need to do to move beyond these descriptors of data-driven approach of these approaches to precision psychiatry. This example will probably be familiar to most of you. It received quite a splash a few years ago when it was published. This is a paper published by Andrew Drysdale, who is a student in Connor Liston's lab with a whole host of collaborators, and that tried to look at what characteristics of an individual's brain might define different subtypes of depression, and whether characterizing individuals by these subtypes of brains might lead to some clinical utility. The approach is data-driven because it takes data, pre-existing data, in a theory-agnostic way, and asks what about, in this case, the connectivity of the brains of these individuals might predict something useful from a clinical perspective. Essentially, the approach was to take some 2,000 individuals with depression from a number of different studies, really across the US, including some here at Stanford, and measure the functional connectivity, that is the temporal synchrony between activity as assessed in a fMRI scanner, the temporal synchrony between nodes of putative networks in the brain, and create a functional connectivity map of each and every individual. So you can imagine these two gray nodes here. Activity is going up and down over time in those two nodes. And you can see that from the dotted line and the dark line trace that these two nodes activities tend to go up and down together. And so these, you could say, are highly functionally connected. And on the right-hand side of the slide, there is a map of all of the connectivity of all of the putative network nodes of the brain, with strong positive connectivity in warm colors, strong negative connectivity in cool colors, and dim colors or places that are not connected. The important point is not the details of this individual's connectivity map, but the very fact that a map can be created for that individual person, and then compared to maps of the other 2,000 individuals with depression and clustered into groups. And that's indeed what Drysdale and colleagues did. They came up with a clustering system that created 4 clusters. Of course, we know that these clustering algorithms aren't necessarily very precise, but nonetheless, this group came up with 4 clusters and then asked whether the brain patterns of connectivity predicted anything useful from a clinical perspective. In particular, they looked at the responses of a subset of these individuals to a particular antidepressant treatment, transcranial magnetic stimulation to the medial prefrontal cortex. And they found that if you had MAP type 1 or 3, you were more likely to respond to this treatment than if you had MAP types 2 or 4. And the improvement was correspondingly larger in MAP type 1 or 3 than in 2 and 4. And so looking at the strength of connections of an individual's brain and the map of those connections, one can potentially make an inference about the likelihood of that individual to respond to this particular treatment. Now, as I pointed out in the past, and several of you probably heard me point it out, this is an interesting observation, but not yet a clinically useful one. Why do I say that? Because it's possible that individuals of, say, MAP type 2 and 4 are simply resistant to all antidepressant treatments. And my decision as a psychiatrist treating a patient in my office is not whether to treat them or not to treat them, but rather which of the many options that I have to treat individuals with depression, which are more likely to be effective in this individual. And so characterize them as biotype 1 or 2 wouldn't help me decide whether to treat or not, because I'm not trying to make that decision. But if I knew that biotype 2 would respond, say, well to fluoxetine and not so much TMS, or CBT and not so much TVS, well, that would help me tremendously. And that's what we are asking individuals to do now, scientists to do, as they're creating these studies to try to identify biomarkers that are clinically predictive that we could use for precision medicine. So that's a data-driven approach. What do I mean by a theory-driven approach? Well, a theory-driven approach, instead of just taking a whole bunch of data about individuals and then asking whether whether one characteristic of that individual predicts a clinically useful variable. In this study by Rob Rutledge, who was at the time in Ray Dolan's lab, they took a theoretical approach, asking, well, what within a particular system that we think might be important for depression, what are the different ways that that system might go wrong? How can we describe that system well so that we can then go about measuring it in individuals with depression and figuring out which individuals have deficits in that system? So let me stop saying that system and describe what system I mean. What I mean is the system that we have in our brains to learn from past experience. And one aspect of learning from past experience is learning from the presence or absence of rewards in the world. And we have a very well theoretically described system for doing so. And so Rob took this smartphone-based game where you could press one button to get a known reward and another button to get a variable reward, had individuals play this over and over and over again, and then in between trials of playing the game, ask them to rate their happiness in the moment as they were playing the game. And from the theoretical descriptions of reward learning, Rob developed a hypothesis about what happiness is, or what positive mood is. It's a sum of these various factors, which include baseline happiness, that's the W0 term here, a function of the rewards that you've already received, that's the first sigma function here. The second sigma function is the third parameter, which is the expected reward that you expect to get on the trial, on each of the trials that you've already played. And then the fourth one is the reward prediction error, or the difference on each trial between what you expected and what you actually received. So how happy a person is while they're playing this game can be potentially described by these four different factors. How well does that describe the actual mood ratings the individuals put in? Actually turns out really well. Sorry, I thought I had that on the slide. It's not. It appears not to be there. But the correlation values are well above 0.8 and in many cases 0.9 across really thousands of individuals who play the smartphone game. Then you can ask, where does happiness reside in the brain? And many of you know that's a fruitless endeavor. You can't really figure out where happiness lies in the brain. But if you try to look where some of these parameters lie in the brain, you can find out that actually things like reward prediction error very reliably are associated with activity in the ventral striatum and the medial prefrontal cortex. And then through a meta-analysis, you can show that deficits in reward prediction errors fairly reliably across groups of individuals with depression are seen fairly reliably across groups of individuals with depression. Now, we're not yet in precision medicine in doing this. This is, of course, all across all people with depression. But once you have broken down behavior into these component parameters from a theoretical approach, you can then ask whether there might be subsets of individuals who have a baseline happiness deficit and subset of individuals who have deficits in reward prediction error, and therefore target different treatments to them depending upon which part of this learning algorithm is broken. And then, of course, there may be individuals with depression whose learning algorithm is just fine. It's entirely intact, but who have depression for other reasons. And so, again, one might target different treatments at different individuals depending upon how they fit into this theoretical description of mood-related behaviors. Now, what I want us to do, though, moving forward is to think carefully about when theory and data-driven approaches are potentially useful, but even more importantly, to think about how we might combine theory and data-driven approaches. So I'm showing here this figure, this quite well-known figure that my predecessor, Tom Insel, and colleagues put out to explain the RDoC-based approach to transdiagnostic explication of illness and pathophysiology. But I'm going to use the same figure to argue that we really need to think about combining theory and data-driven approaches to better cluster individuals, better identify individuals, and target them with precise treatments. So here on the left of this slide, you see individuals, all comers, regardless of diagnosis, who are experiencing depression. You put them into a big group, and you get a lot of data on them. And the classic data-driven approach would be to take all this data agnostic to theory and use it to derive categories that might be able to then fit them into stratified clinical trials or other data-driven approaches to figure out which of these clusters of individuals might respond better to one treatment or another, or might have some other clinically useful variable associated with them. I want to point out, though, that one of the things here we're talking about here is behavioral processes, and these can be theory-based behavioral processes. Similarly, physiology can be theory-based markers, so that, for example, we might, in behavioral processes, include these measures, these theory-driven measures of reward-related behaviors. And in physiology, we might include theory-driven variables such as stress response markers, etc. and allow, therefore, once these things cluster into groups, one to take mechanistic approaches to the cluster so that you're not just taking, like in the first example, a random grouping of individuals and figuring out which treatment they might or might not respond to, but you're actually making predictions based upon those theory-driven variables you've included, predictions about which groups are going to respond to which existing treatments, and maybe even target novel treatments at mechanistic targets that are identified in subsets of these clusters. So combining theory and data-driven approaches is really an important aspect that we need to think about as we revise our frameworks for precision psychiatry. The second revision I want us to think about is how we conceptualize a diagnosis. So this is the way that we think about a diagnosis most commonly, not just in psychiatry, but really across medicine, although the examples I'm going to show you are psychiatry. We think about a diagnosis as being a disease process. That disease process can manifest with causes such as genetics or environmental causes, with pathophysiologies such as neural circuit or neural system pathophysiologies, but that it encompasses some entity, now admittedly loosely defined and heterogeneous for psychiatry, but nonetheless an entity that then causes symptoms such as, if we think about depression, changes in mood, energy, and concentration, etc. But actually, that's not what happens, at least not when we think about it from a diagnostic perspective, as opposed to a disease perspective. What really happens, before I get to what really happens, now let's throw in our transdiagnostic phenotypes like RDoC domains, or like the reward learning phenotype that I just told you about, or for that matter, like the functional connectivity phenotype. And one again thinks about the disease entity as causing symptoms as well as alterations in these transdiagnostic phenotypes. So transdiagnostic phenotypes don't really change this essential conceptualization of the diagnosis or disease causing observable phenotypes. But really what we have to recognize is that, yes, a disease process of some sort, or multiple disease processes, causes alterations in transdiagnostic phenotypes and alterations in symptoms. But the diagnosis is not on the left side of this graph, really. It's on the right side of this graph. That is, diagnoses are not entities of disease. Diagnoses are descriptors or observations made by trained clinicians. And so we can't think of diagnoses, at least, as being diseases that cause symptoms in transdiagnostic phenotypes, but we have the powerful ability to think about diagnoses as another outcome of disease as opposed to the diseases themselves. Why do I say that's powerful? Because we can combine diagnoses, which are reasonably reliable, somewhat predictive descriptors of our patients, combining them into our theory and data-driven frameworks for precision medicine. But more importantly, if we think about it from a computational perspective, which I'll get into in a moment, if we think about it from a computational perspective, we can add the diagnoses into our outcome measures, not in terms of outcomes of treatment, but outcome measures in terms of how we are measuring our patients, as another thing to think about that's an indicator of whether a patient's going to respond to a particular medicine, whether they're going to have a particular longitudinal course, and quantify it with math to figure out how much information about the disease the diagnosis actually gives us, just as we can do with these other theory and data-driven approaches. So what do I mean by that? In order to tell you more about what I mean by that, about how thinking about a diagnosis as an outcome of a disease as opposed to the cause of symptoms can help us, I'll now going to turn to the integrated approaches that I think we need as we think about moving forward. And I'm going to start again with RDoC. This is our new RDoC logo, but more than a logo, it's really a new framework also for thinking about RDoC. It gets away from the matrix, which too often is seen as limiting or forcing people to think in a particular way, and now we're describing it more as a framework that incorporates domains of behavior, units of analysis, environmental causes, and developmental and lifespan approaches in a transdiagnostic way. So let's start with this, though, as a way of, with a focus mostly here on the domains, as a way of thinking about how you can break down behavior into its component parts, number one, and number two, as a way in which you can measure those component parts in our patients to get additional observable data about our patients in addition to their symptoms and diagnoses. And now, if we start with RDoC and ask, what can RDoC do to help us improve our clinical predictions above and beyond what diagnoses can provide? This is where we can get into the integrative approach I'm talking about. And I want to give full credit to those individuals who came up with a specific and I think quite promising integrative approach, although I don't mean to say that this is the only thing that we think will work at NIMH. And this is a group of individuals who wrote a chapter in this book that Dave Reddish and I put together. That's the outcome of a forum, a meeting at which these individuals and others came together for a week to think about computational psychiatry in general. And this particular group, led by Shelley Flagel and Danny Pine, but including a number of other individuals. This particular group was in particular charged with asking, what can computational psychiatry do to help develop, to help in terms of the diagnostic framework, but they came up with a larger approach than just diagnoses. I also, just so you know, because it can be hard to find book chapters, although I'm happy to send it to you if you'd like, we recently published an article that elaborates on this approach for schizophrenia research that should be available more widely. So what is the approach? Again, we're going to start now, in this case, with DSM diagnoses and ask, how do we integrate RDoC into this approach of DSM diagnoses in the service of more precise characterization of our patients? And here we want to emphasize a computational approach for detecting relationships and patterns in complex multivariate data sets, and importantly, has to make clinically relevant predictions. So we start with their DSM diagnoses. We want to add into that RDoC behaviors. And now here's the crux of the matter. If we think of diagnoses not as disease causative agents, but as observations about our patients, then they are very much at the same level as RDoC behaviors. They reflect some underlying latent constructs in the brain and in the person. So in terms of RDoC behaviors, one of those constructs is, for example, the reward learning process and reward learning pathway. In the case of diagnoses, we don't necessarily know what those latent constructs are, but they may relate to some of the latent constructs that underlie RDoC behaviors. And that's, of course, one thought about why to turn to RDoC in the first place. But in this case, again, if we think about both of these things as data points about our patients, they reflect underlying latent constructs. Those latent constructs derive from what we might consider hidden physiological states of the brain. Of course, they're not always hidden to us if we use fMRI and other things, but we can think of it as hidden physiological states of the brain. And those hidden physiological states arise, of course, as a complex interaction between primary causes like genes and environment, and of course, developmental pathways and plasticity. This framework of integrating the RDoC behaviors alongside with DSM diagnoses and other symptom-based approaches allows one to think about interpreting all these underlying states from the observations and inferring a causal pathway that goes from the causes through these physiological states of the brain to alterations in latent constructs. And I won't go into the math on this slide, but in the Flagel chapter and elsewhere, in particular, an article that Carl Friston wrote, you can actually use various mathematical approaches to help do two things. Number one, try to identify what some of these hidden physiological states and latent constructs are. And two, ask what percentage of the clinically relevant outputs are describable by diagnoses, by RDoC behaviors, and ask then, how much might it be worthwhile to add these additional observations of our patients into our clinical practices in a quantitative and computationally derived way? And I'll say only this about the math, that in this particular instantiation by Flagel et al., the approach is a Bayesian approach that allows one to ask how much better you can do with new data than you were able to do with your prior grouping of data. So this is one framework that really focuses on these observable variables. Again, thinking about a diagnosis as an observable variable about our patient. How might we, though, develop the ability to actually test this and other kinds of frameworks that combine theory and data-driven approaches? And this, then again, I'm going to come back to all of us, although I don't think all of us is the only solution. Importantly, the all of us cohort, in addition to accumulating all the various data types that I mentioned earlier, enrolls these individuals in ongoing evaluations of their health, and importantly, engages them in repeated interactions with the All of Us program. And one of the things that All of Us and NIMH are working together to do is to bring theory-driven computational behavioral types to the All of Us program so that we can actually measure RDoC relevant behaviors in theory-driven and defined ways, and then ask how much more we learn about our patients clinically by combining those behavioral tests done remotely through smartphones and web access in these very large groups of patients. We can combine those results with the results that we get from the EHR in terms of diagnostics and in terms of clinical outcomes and treatment responsiveness to begin to unravel the relationships between behavior, diagnoses, and clinically relevant outcomes. We are doing this now with the initial groups of 5 behavioral tests that look at emotion identification, sustained attention, reward learning, risky decision-making, and response inhibition. But it's the plan to roll out as many tests as we can validate in this group so that we can use this tremendous resource to begin establishing frameworks for precision psychiatry of the future. We also recognize that there are lots of other things that we need to do if we want to foster precision psychiatry across our portfolio. So we have a number of announcements, some of them linked here, to develop novel behavioral approaches, some of them translational, including focus on computationally defined behaviors in in model animals, as well as a new concept that we just cleared yesterday it's out of order here, to develop the data infrastructures and clinical decision-making tools that would use the data we're deriving from these interactions. I'll come back now to one more thing. We recognize that this is a long-term vision, and we need short-term approaches as well that can make a difference with a shorter time frame. And so we just announced at our council a new initiative under development in precision psychiatry to fast-track tools that have the potential to predict treatment sensitivity in depression based on the work of Drysdale and the work done here at Stanford by Leanne Williams and others, and the work really being done in many other places, showing that there are biomarkers that can make clinical predictions. This set of initiatives that will hopefully be launched starting in fiscal year 2024 will try to take the most promising biomarkers and, with involvement of the FDA, advance them to the marketplace. And I'll mention one more thing and one more resource before closing out. And that's that we also have a data archive at the NIMH where we try to make sure all of our data is shared and available to everyone, including data from the programs that I talked about today, so that we can ensure everybody has the opportunity to build on what we learn and develop the precision approaches of the future. Now, I really want to close out the talk by focusing on an aspect that I've really not yet mentioned, even in the first three parts of this talk, but is crucial if we want to make sure that the precision medicine tools that we are developing actually help all Americans and not just those who belong to, say, the majority group or who have access to resources. We need to make sure that as we move towards precision psychiatry, we take into account and study all of the populations of the US, but especially focusing on those that have historically been underrepresented in our research and have historically underbenefited from advancement in biomedicine. One of the best ways that we can do that is to make sure that the people conducting the research represent the true diversity of America. And so I want to talk to you for a moment about NIMH's diversity, equity, inclusion, and accessibility initiatives, with a focus in particular on the extramural workforce, although I will also say we're doing a lot of work to try to diversify and make more inclusive the internal NIMH workforce as well. Just two gatherings that we had recently, not because they're the first that we've done, but because they're illustrative of the efforts that we've been engaged in. In January of this year, we held virtual listening sessions with extramural investigators to understand barriers and facilitators to achieving racial and ethnic equity in grant funding success, or how we close the so-called Ginther gap for those who've been paying attention to this area. This featured panels of researchers from multiple career stages, and we have synthesized the output of those results. And we just recently presented that at our open council meeting last week, as well as some things that we've done, some of which I'll present in the next slide, to try to respond to what we're learning from our investigators. Now, from a career development perspective, we have a lot going on, but one of the things that we just recently did was participate in the NIH Diversity Supplement Professional Development and Networking Workshop. This is a workshop that was initiated by NIDA, but which an NIMH was an early participant in, where we bring together all the scholars who are supported by diversity supplements, including 45 of them supported by the NIMH, and put them through expose them to a number of different career development and science development workshops. I had the pleasure of spending an hour with the NIMH supported supplementees, answering many of their really tough questions, and giving them my perspective on the future of research at NIMH. But we don't just have gatherings, we put money where our mouths are. We have a range of different offerings really across the career pipeline pathway, from these supplement words, of course, that many of you are familiar with, that allow investigators to hire additional personnel, provided those personnel represent a diverse or underrepresented perspective. We have pre-doctoral fellowships, postdoctoral and career development awards that are support individuals from underrepresented backgrounds to progress through their research development. And then finally, we have begun participating along with other institutes in efforts to support diversity at advanced career levels as well, including our participation in the Common Fund program, the first program that supports recruitment of diverse faculty members to institutions, as well as our brand new R01 that is targeted at individuals from underrepresented backgrounds and others who support a diverse workforce. And that R01 program was launched this fiscal year. So with that, I'll close out And I'll say that we envision a world in which mental illnesses are prevented and cured. We seek to transform the understanding and treatment of mental illnesses through basic and clinical research, paving the way for prevention, recovery, and cure. And we, especially at NIMH, know that we can't do this without developing better and more precise ways to characterize our patients, to make clinical predictions, and to bring those tools to bear on the problems that our patients face. And with that, I'll stop sharing and leave it open to questions. Thank you so much for having me, and I'm looking forward to our discussions.
Dr. Gordon, thank you so much for sharing such an inspiring vision for our field. You really are charting the course for precision psychiatry and the integration with computation and neuroscience in a way that will create positive change, not only in the lives of so many researchers and scientists, but in the lives of so many across the United States. I also thank you for being willing to start early and to take a slightly extended question time. I know there'll be many questions. For those of you who were concerned at missing the beginning, we'll have the recording. I wanted to congratulate you, Dr. Gordon, on the new initiatives, the infrastructure and the precision psychiatry initiatives. Very exciting. So now we will take questions from both in person and from on chat, and I am supported very well by Rachel Hilton on the chat questions. So first of all, if you have a question, please come to the microphones and we will make this technology work. So, Carolyn. This is Carolyn Rodriguez, Josh.
Hi, Josh, how are you? First of all, I just want to say thank you so much for really taking the time to describe diversity, equity, and inclusion and accessibility, and just wonderful to see the new initiatives and all the energy and momentum. And I know it's something that's near and dear to your heart, and it's nice to see it work its way through the system and get all of the approvals, which I know you've been really keen to do. So I just want to say thank you so much for that.
Thank you, Carolyn. And I've learned a lot about that and many other things from you. So appreciate your efforts in many areas.
Thank you. And so my question is kind of a sort of existential question. So as the technology and the biomarkers develop, so for example, Connor Liston's beautiful study looking at, and you mentioned this as a clinician, right? Should we start an SSRI or should we do TMS? But in some ways, the field of TMS is really evolving so rapidly. And one amazing example of that is the theta burst simulation. And so when we have a patient in front of us, there is SRI, but there are different kinds of SRI. And with TMS, there's a lot of different kinds of TMS, and it's just a field that's exploding. Where to stimulate, how to stimulate, how frequently. So I just want to, more again, sort of existential, as we're, are we building the ship as we're flying it in terms of some of these markers?
That's a really great question, Carolyn, and very, very thoughtful. First of all, I have to say, I love the wide view. I'm totally distracted by how enormous my head is in that room. But now, if I can focus on your question, I promise that this is where we really need to think hard about the theoretical approaches, right? So already we have an attempt at this in the partial answer to your which SSRI to use, right? So there are now these pharmacogenomic tests. They haven't been shown that they work in terms of speeding therapy, so I'm not endorsing them at all, but they are a theoretical approach to the problem of which SSRI do I use? Well, some of them are metabolized by different enzymes. And so if we knew that you had too much of this enzyme or a little less of that, then we might make a prediction about whether one SSRI will work better than another. So that's one example of a theoretical approach. The TMS thing is another example. I think in general in the TMS field, we need much better theories about why a particular treatment might be working and about how to target that particular treatment. I don't think we have the right TMS for anyone yet, not unless everybody. And so we need more work in that area to refine how these things work and where to target them, et cetera, in order to be able to then put that into the equation from a data-driven approach of, well, which patients are going to work better. So I think theory can help us parse out the many, many options that we have to focus in on the ones that are more likely to work in this or that group of individuals. So that's one answer to your question. Another answer to your question is that we don't have any guidance right now, right? So anything that we learn about just skewing the likelihood of response in one direction or another would be really helpful. And let me just give you one example to crystallize that a little bit more. So yes, we may not know exactly which TMS to do, but if we had some data to suggest that this person's going to respond better to TMS than SSRI, that would be useful information to provide the clinician and the patient so that they can make an informed decision. However, it has to be quantitative. And we also have to think about, sorry, there's a train in the background here. We also have to think about what problem we're trying to solve. And I'm going to give you one example that illustrates the importance of both of those things, quantitation and thinking about the solution that you're trying to go after. We recently funded a study that's going to be taking place in a province in India. I forget which province. I think it's in Goa, but I'm not sure. In any case, they're going to take data from their entire provincial-wide mental health care system and try to look for demographic and symptom predictors of response to CBT and compare it to fluoxetine. Now, why those two? Because as many of you know, the WHO trains lay healthcare providers, has a program that you can use to train lay healthcare providers to provide depression care, and those are the two options, fluoxetine and CBT. And now, if those of you in the room will appreciate this, I'm sure, the likelihood that we would be able to take a symptoms plus demographics and make a reasonable prediction that would be good on an individual level, let's say, oh, you should get fluoxetine, and you should, that the FDA would say, oh yeah, that's a good biomarker, is incredibly low. And so my first thought of this is, why would we ever fund this grant? But then my colleagues at NIMH, who are healthcare economists or who understand healthcare economics, pointed out to me that the marginal difference that they need to save money on a province-wide basis is much smaller than the marginal difference that we would need to be able to say, oh, in America, yes, you should get CBT versus fluoxetine. They just need to save a tiny little bit of money to be able to cover a lot more people. And so even if the predictor isn't all that good, if the ROC is only 0.6 or something like that, instead of the 0.8 or more that we might demand, that's going to be a useful predictor from a public health perspective to be able to reach more people with depression. So, but you need quantitative numbers. You need to know not just is it better or not, but how much better it is to then know whether it's worth putting that predictor into play and whether it's cost effective, right? So you need quantitation and you need to understand the problem you're trying to solve. I hope that's maybe it's more long-winded an answer to the question that you asked, but that's the answer that I would give.
Thank you so much, and Josh, and thank you for your work.
I believe we have, and thanks for the question, Carolyn, great question. We have questions in the chat, which Rachel will read out.
Yes, one of the questions that we have is from Craig Bouchon in our Zoom, and he says, you spoke to the development of tools to inform treatment selection in depression. Can you speak to the work that is developing biomarkers and tools that are integrating individual pre-treatment measures to predict response among multiple treatments in the area of substance use disorders?
That's an easy answer for me. It's a very unsatisfying for you. No, I can't speak to that. Part of the reason I can't speak to that is, believe it or not, at the National Institutes of Health, substance use disorders are carved out from mental illnesses and handled by another institute. So I really don't know what is going on in that area. I know there's a lot of interest in it, but I can't really tell you much about it. Sorry.
That's okay, because we have plenty of more questions. So next, from another participant, we have, for the biomarkers which you mentioned, they can be used as evaluation markers for treatment efficacy. Means with treatment, the biomarkers are also changed with the symptoms of improvement. If in this case, what are the best biomarkers thus far? Any chronic inflammation markers or something else?
Yeah, so again, an easy answer. I don't think we know. Maybe others in the room might disagree with me, whether there are any that are good indicators of treatment response. You might hear about some today that are under development. Certainly, a lot of the ones that we look for to being good treatment response biomarkers are, for example, in this case of wearables and other passive monitoring devices that seem to follow to a certain degree symptoms over time. But I think it's really important that we develop them. At NIMH, we are supporting an effort to define biomarkers, for example, in autism. In this case, there are two biomarkers that we've been funding the development of. One is a behavioral biomarker around observation of faces, and the other is a neurophysiological biomarker that indicates the neurobiological response to face presentation. And both of those biomarkers are currently going through the FDA approval process with the idea that then we could test whether they respond to treatment or not. But it's too early to know whether they or any of the other various biomarkers that we have will do so. And again, I invite other members of the audience or you to pay attention to the rest of the day, where you might very well be hearing about some that have the promise of being response-based biomarkers.
I know we have more questions on Zoom. For those of you in person who have questions, please feel free to come up to the microphones that are at the back of the room here, or call out your questions by putting up your hand that you have one. Rachel, I think you have more in chat.
Yes, in the Drysdale paper mentioned as an example of data-driven approach has well-documented methodological pitfalls, as in its replication has shown that similar resulting clusters can be attained by sampling Gaussian noise. Can you comment on this and more generally on the challenges of following a data-driven approach and on the actual evidence of the existence of biotypes of depression based on brain data?
That's a great question. I won't get into the argument, which I know is a fierce one, about whether the particular approach that Drysdale used has been or has not been replicated, and maybe others will do so later on in today. But nonetheless, the problem of replication is one that we really need to solve before it can advance biomarkers to application. So first and foremost, I think the field needs to arrive on a set of conventions for what is adequate proof of replicability, in much the same way that the genomics field has already done. You can't publish a paper in genetics these days unless the association is replicated in two independent data sets. And I think some form of that, as well as conventions around, comparing, prioritizing different approaches of generalizability. Many folks use develop a machine learning or clustering or whatever approach on half your data and then test it on the other half. Others use a leave one out iterative approach. I'm not an expert in this area. I don't know what the right ways are, but I think the field needs to develop those approaches so that before a paper is published, it is already proven to be at least somewhat replicable or somewhat generalizable. So I think that those are important things that the field needs to establish. And if there's a way that NIMH can help do so, by all means. We actually are convening a work group, not unrelated to the biomarker issue, but it's not focused only on biomarkers. We're convening a work group of counsel to plan an approach to what we're calling high dimensional data sets that will address some of these issues. So we will be coming out with maybe recommendations, maybe requirements for NIMH funding, but I think it's a field-wide issue. I'll mention another approach that is baked into the initiative that we just announced last week at Council on predictive depression biomarkers. There we are going to be actually funding phased, I forget the phases, but we're funding iterative trials you think of the Drysdale paper as raising the hypothesis, right? That connectivity could be a predictive biomarker in depression. And what we would fund, again, we're not necessarily going to fund that approach. We're going to have an open call, there'll be competition, but what we would do is fund an actual trial that's designed in a prospective, controlled way to figure out whether that would actually work in a new complement of patients in a prospective way, where patients would undergo the biomarker and would be and then the biomarker, they would be appropriately controlled, and the biomarker efficacy would be tested. At first, a sort of phase 2 smaller trial, and then ideally a large phase 3 trial that would enable FDA approval of the biomarker.
Wonderful. I think prospective trials will be so important for our field. We have a question from the floor, so please go ahead.
Thank you very much for a very clear and excellent lecture. I wanted to ask, in your talk, you talked about predicting the efficacy of current treatments, like and personalizing CBT, SSRI. What about the investment of the NIH in novel treatments, novel molecules, and repurposing of current molecules? I know a few years ago it was kind of a main mission in the NIMH. Has it changed?
It's not. It hasn't changed. But as you well know, we at NIMH feel very strongly that our role is a mechanism-focused role within drug development. So we don't fund studies that just seek to ask whether an agent is clinically beneficial, but we actually require you show that it's engaging a mechanism. In terms of the biomarker space, in terms of the precision medicine space, we are interested in and continue to support work that would fund biomarker development that would use that mechanism-based approach to develop novel therapies that are targeted at novel mechanisms. And so I think, yes, we are still interested in this area generally.
Thank you for the question. Usha, you have a question.
Yes, thank you. Dr. Gordon, I come from not from a scientist perspective, but as a parent of teens and young adults, as well as being a Stanford advocate and supporter. I was just thinking, with the pandemic, the teen mental health has really taken a hit. And we don't have 5, 10, 15 years for all of this to come together. So I was just wondering, from a policy perspective, from looking from a National Institute of Mental Health perspective, how can we speed up some of this research and the tools you're talking about? We were able to do that with COVID. I mean, we got things through really fast. So I'm just wondering, there's a crisis, Vivek Murthy talks about it, but we still seem to be sort of quite far away from personalized medicine necessarily. So I'm just wondering what your perspective is on that.
Well, thanks for that question. And you get to a lot of issues that I didn't really talk about today or address today, so that this enables me to do so. First and foremost, I have kids of my own who are not quite teens. Well, actually, one is still a teen, but who were both mentally impacted by the pandemic. And so I feel the pain of all parents out there, of all the kids out there who are challenged with it. And we recognize at NIMH that we have a responsibility in two ways to address the crisis as it is defined by Vivek Murthy and others. We have two aspects to which we're responsible for trying to help address it. Number one is to make sure that policy approaches that can be put into place now follow the research that we have funded over the years and that have already established, to the extent that we have, evidence-based approaches to taking care of our teens and our children. We actually engaged quite often with our colleagues at HHS and at the White House to help inform President Biden's unity agenda, which has resulted in actually substantial increases in funding for things like school-based mental health care. And our research funded by NIMH and others have shown that school-based approaches are much more efficacious at reaching youth than traditional healthcare-based approaches to mental health care. So that's just one example of other ways that we're trying to make sure that our research that has already been concluded is informing policy decisions now. The harder problem is how we can ramp up our research infrastructure in specific areas to make rapid contributions. And rapid, even for research that might be rapid, the rapidity is probably not going to be fast enough well, it's certainly not going to be fast enough from my perspective to help my own kids rapidly enough. But it's as much as we can do. So in that vein, we have put out a number of calls and supported a number of research projects aimed at understanding how to deal with the mental health effects of the pandemic, whether it be the direct effects of having been exposed to the traumas of losing a loved one, or the indirect effects of school closures and other viral mitigation strategies. So that research is ongoing. Some of it has already been published. Most of what's been published so far has been quantifying the impact, not mitigation measures to reduce it, but we are studying various approaches, including school-based approaches and others. But even that, as you know, a research study, even a fast one, is going to take a couple of years to do. What would we need to do something on the scale of what was done for COVID? Well, think about how much money was spent to get those COVID vaccines out fast, right? And vaccines are a real easy problem. All right. There were decades of research so that we knew exactly how to do the RNA vaccines, for example, even before COVID came along. So I think more resources are necessary if we're really to ramp up research infrastructures beyond what, to respond to rapid crises. We've done what we can with the funds that Congress gave us.
Thank you.
Thank you so much for the question. We'll take one more from Zoom. Rachel.
Yes. The next question is, why would we use clinical relevance as a benchmark for the accuracy of our predictions? How is it different from clinical scales and et cetera?
Yeah, so that's a really good question. I appreciate it. When I say clinical relevance, what do I mean? What I mean is that if we're going to go to the trouble of developing predictive biomarkers, let's make sure they answer questions that clinicians need to answer, right? So I gave the example before. If you're just predicting whether a patient's going to respond to a treatment, to any treatment, and so you're saying, I can tell whether this patient is going to be treatment responsive or treatment non-responsive. It's not very helpful, right? Because I'm not going to tell the patient who is more likely to be non-responsive, go home, there's nothing I can do for you. I'm still going to try to help their depression, right? So what I really mean by clinical relevance is it telling us something that will be useful for the clinician in their interaction with the patient? It doesn't have to be treatment prediction, right? We can argue that we actually do have biomarkers in psychiatry right now. The most robust ones that we know, although are not clinically predictive right now, but they are explanatory biomarkers. And what I'm talking about, of course, is for about a quarter of kids diagnosed with autism, we can tell them the gene in their genome that contributed the bulk of their risk for autism, these large effect size mutations for about a quarter of kids with autism. Now, it does not help guide treatment yet for those children, at least not for the core symptoms of autism, but it is useful for the family, for the clinician, and to a certain extent for the children as well, to know why they have autism. So I would argue that is a clinically relevant biomarker, even though it's not making a treatment decision easier. But again, focus on the challenges that the clinician faces. In this case, the challenge the clinician faces is helping parents come to terms with why their child has autism, and giving them a gene can be incredibly helpful for the family. So let's try to solve the problems that clinicians are facing with our biomarkers and not just make quantitative predictions about things that don't actually help us.
Thank you for highlighting the clinical relevance, Josh, and for taking so many questions. We have time for one more, which will be from Shui Chang, who's in person.
Hello, Dr. Gordon. My name is Xue. I'm a postdoc in Lian's lab. Thanks for this very insightful talk. I just have a question regarding one domain in the RDoc concept. It seems like the somatomotor domain, which seems to be paid less attention than like positive and negative affect domains. I think one reason is probably because it's hard to define like how this domain is linked to subject's function. For example, it can be physically low energy, or it can be like emotionally or low motivation. So I was wondering about your thoughts, because this network came a lot of times during our analysis.
Well, it's interesting that the network popped up in your analysis, and I hope you pursue that. I acknowledge that it has received less attention from NIMH. In fact, we only defined it as an RDoc domain a couple of years ago, right? Long after the other domains were specifically called out. We're psychiatrists. We think about emotion all the time. But it took neurologists to help us realize that our patients were having tardive dyskinesia, right? So somatomotor domain is important for many of our illnesses. You pointed out its importance in depression, and I would say continue working on that. We do define what we will and won't support in it, especially from a basic science perspective, because other institutes are, for example, charged with trying to figure out the mechanisms of motor control. Or how nerve impulses are translated into muscle contractions. Those are the domains of other institutes at NIH. But if there's a compelling association between the somatomotor domain and mental illness, we'd be happy to help you figure out how you can explore it with NIMH funding.
Thank you.
Thanks for the question. And thank you again, Dr. Gordon, for such an excellent plenary and question and answer session. We are absolutely honored that you opened our symposium today. We thank you for your ongoing engagement, your vision for our field. We really appreciate your involvement in today's program, and also for sharing your insights with many of our early career investigators. Very much appreciated. We will now take a break. We will resume sharply at 11 a.m. And we will be in for another treat with Dr. O'Hara, who will kick off our keynote program. I will see you back then.